wonderful. Congratulations to all of the speakers, wonderful projects, and we are truly in good hands as we age in this organization. So thank you so very much. So we're going to go on to our last speaker for the day, and definitely not least. Over the last several GOGS organizations, including Medical Association of Georgia, Georgia Perinatal Quality Collaborative, have begun working to improve cardio-obstetric coordination. Our next speaker, Dr. Suchi Chandrasekran, is an associate professor in the Division of Maternal Fetal Medicine at Emory University and holds additional faculty positions in global health at Emory and the University of Washington. She earned her MD from Northwestern University and a master's in clinical epidemiology from the University of Pennsylvania. She has received numerous awards, including the Emory Physician Service Award in 2022 and the GYN New Investigator Research Award in 2023. Dr. Chandrasekran is also a published author and active community volunteer. She was just elected to the GOGS Board of Directors as the member at large. Please welcome Dr. Suchi Chandrasekran, and the talk is on the 4th trimester and beyond, optimizing postpartum maternal cardiometabolic health.
Thank you guys. I know I'm the last talk, so we'll keep it as entertaining and hopefully we can stay awake as possible. I am giving this talk with someone here that this program wouldn't have happened without. This is Dr. Natalie Polyaktiv. She is our first-year fellow in maternal fetal medicine. When I started this clinic we're going to hear about, she played a key role in this process and has continued to be a extremely helpful logistic player and present data in it. So both of us are going to give this talk together. Now the hardest part is figuring out the thing, so help me. Big green dot. Wonderful. Oh, look, and it's here. And I'm short, so we'll put this down. Okay, excellent. So I have no financial disclosures. I do have a personal disclosure. I am a mom of 2. I have an 11-year-old girl, 8-year-old boy. I've had a baby in the NICU, and I've definitely had firsthand experience in experiencing mom's health postpartum as a third-year fellow at the University of Pennsylvania in MFM. So let's start with what's the problem and what's the issue, and then we're going to talk about a small solution that we did and that we started up, and then we're going to talk about the data. What did we find? Was the solution helpful, right? What's the point of doing solutions if they don't work? And then finally, the future. Where are we going, and is there a point to what we're doing? So, starting with the problem, what's the issue? I'm going to first start with what is postpartum. And I see a lot of us as women in this room. I know a lot of us are mothers here. So we're going to start with this. So you know what Google says postpartum is? I love this. Google says the postpartum period begins soon after the delivery of the baby and usually lasts 6 to 8 weeks and ends when the mother's body has returned to near normal. I'm not pre-pregnant, guys. I'm just gonna tell you that, okay? My dress size, my everything size is not pre-pregnant. So if that's postpartum, then I'm still postpartum. I'm gonna claim that. Merriam-Webster, another good one, right? So what is postpartum? Occurring in or being the period following childbirth. So I think we're all there. So then we're all postpartum, I mean, in theory. Well, NCI, right? Like a little more maybe scientifically drawn. What is postpartum? They actually say that postpartum is the time that begins right after birth and goes to about 6 weeks, under the idea that physiologically that's when your body potentially changes back to normal, but we also know that that's not completely true. So then let's go to ACOG, because that's our organization. What does ACOG say? ACOG says that postpartum is up to 12 weeks following the birth of a child, and that it's a time where you have to heal physically, mentally, emotionally, feel good about your health and baby's care, and then see if you can ask for help with that. But does everybody really get that within 12 weeks? And then ACOG says, this is our postpartum checklist. So we have to do all of these things, but generally in a 20-minute OB return visit, maybe 40 minutes, but all in a postpartum visit at 6 weeks out. Well, then let's talk about what is postpartum for the actual patient. Well, as we all probably know, there's some of that, there's probably some of that, and there's probably some of that. That's the reality of postpartum. What do we think postpartum should be? This is what a lot of women feel, right? They feel like they should be doing all the things. They should be walking, working out, exercising, taking care of their baby, eating healthy, all this stuff. We've all been there. We know that overwhelming feeling, and we know it's not possible. And this is generally how I think most of us feel. So I'm going back to this question of what is postpartum, and I think that's the entire crux and key of what needs to change as a paradigm shift, and I think that is actually what is changing in the process, is what is postpartum. I actually learned that the 6 weeks rule happened in like the 70s and 80s, where it was basically just decided 6 weeks sounds good, and that's when people kind of come back postpartum. So it's not like we had a lot of necessarily scientific data backing up why we chose that 6-week period. My interest in this area started actually way back in fellowship, and we did a study at that time, a very basic study, where we just looked at the risk perception of future cardiovascular disease in women who had been diagnosed with a hypertensive disorder, just to see what this was. And this was in 2013, right? So a fair time ago. And what we actually saw here is that when you look at the increased risk of myocardial infarction, you can actually see that in terms of moderate risk, only 8% of people with preeclampsia with severe features actually thought they had moderate risk for a future problem. So pretty low. And then when you look at even high risk, only 2 to 4% of people actually thought that there was an increased risk, and it didn't change based on the type of disease you have. So most people don't even realize they have increased risk. It's not coming across. To us, it was getting to be known, but it's not coming across to people. And then when you look at postpartum care in this was a study that looked at postpartum care in a cardio-obstetric clinic after people had preterm preeclampsia, and they wanted to look at like provider and patient healthcare perspective. So it was a qualitative study that was done. This one actually says that, these were quotes they got. They thought delivery once the immediate danger was over, because you're kind of told, oh, the cure for preeclampsia is delivery. And this is actually a much more recent study that was done. So this was done in 2020, so this wasn't done not that long ago. Here's another one. I think I was supposed to have gotten a list of healthcare providers in my area. I don't know what I actually got. I don't know what I was supposed to do. I don't have follow-up. I mean, this is how people kind of naturally feel. And this is still happening more recently, despite the fact we all know that there are these increased risks, and we keep talking about it. So how do we build that connection? Where is the disconnect? What do we do better? And here's the other one, getting used to so much stuff in the postpartum period that they weren't able to really process all that initial information. This is one we hear a lot, and Dr. Polyakov here will get into kind of some of the stuff we've actually heard. And then here was another one that looked at the 4th trimester, a critical transition period with unmet maternal health needs. And this was actually a study that looked at system constraints, and again, talked about so many of the system issues that are such a major issue for postpartum, including culturally appropriate care, conversation-based care, other pieces that go into postpartum that we often don't think about. And then, of course, we keep saying that we need to bridge this gap for training of obstetric providers or patient navigators. And so this is another study that said that training, let me go back here, training should be centered around these 6 cores: health equity, cultural sensitivity, and all these other pieces of postpartum, which can be such an issue. When they looked at interactions between race, ethnicity, poverty status, and kind of other pieces, there's definitely a big significant difference when you look at effects in the postpartum period. This is not new to us. This is something we know. We can see it here when you look at African American, Latina versus white. And then you can also see that when it comes here with income levels. And so again, there's so many pieces going into this postpartum period. And then, of course, we can't forget diet, physical activity, psychosocial well-being. This was a meta-analysis, reviewed 14,419 citations, and definitely psychosocial well-being interacts with diet and physical activity. So this is the complicated pieces that we have to take into account, and it's not just a one-stop shop when it comes to the postpartum period. And then this was another study that came out of actually the NICHD that said seizing the window of opportunity within 1 year in that early postpartum cardiovascular health is extremely important, and definitely have promoted implementation of a multidisciplinary care model. So the good news is we're moving towards that pathway, is this concept of multidisciplinary care models in the postpartum period. It is not just a one-stop shop 6-week postpartum visit. That's definitely where the trend and the situation has to move, and it's a true paradigm and a revolutionary shift in postpartum. And what does postpartum mean? So now we're going to go to the state of Georgia because that's where we are and that's where we want to make improvements. And so, of course, I'm not going to have to harp to this population because this group here knows these numbers, but we know the state of Georgia maternal mortality compared to the national. We know that the affected tend to be those who are Black or publicly insured or uninsured, and the majority of the deaths are within that 64 days postpartum. The MMRC has said that these are the key contributors to maternal morbidity and mortality in the state. They said the majority of deaths do occur intrapartum, peripartum, or postpartum. These are, again, the key players going into it, and 60% are cardiac related. Again, in those intrapartum, peripartum, postpartum period. And this can be seen here from the MMRC report. I need to put the updated one because this was the other one, but the new one has come out. But the numbers are the trends are very similar. And then again, when you look at the timing of the majority of the maternal morbidity and mortality cases, you can see the majority comes in that postpartum period. I know we've briefly touched here already on maternity care deserts, and whether we like it or not, the fact is they exist, and we can't take that away, and we do need to figure this out, however that may be. And of course, we know that means it's, a center that doesn't have a hospital or a birth center or obstetric providers, and this is a map that we have all seen, we all know when it comes to maternity care deserts in Georgia. And we actually saw that the Georgia Board of Healthcare Workforce, their annual report, had gone ahead and put these are the numbers for counties without a physician, family physician, internist, because remember, I said this postpartum period is not just OB. We need that multidisciplinary care, and so this is important for us to take into account is what kind of supportive care are we going to have if we need to think about something like this. And now, before I kind of go into my solution, I want us to take a minute, and I'm going to step back into a few words that I think are really important to address. So the first word is quality, right? What is quality? We're all here. We all want to give quality care, but what is quality care? Quality care is the standard of something as measured against something that's similar. And so it's the degree of excellence in something. Are we doing good or not? And then we talk about equality, which is really important as well, which is equal treatment for all people. But really, probably where we need to go is the word equity, right? The quality of being fair and impartial. So more than just quality or equality, what we need is equity. So now let's go to this. Equality, which is over here, in some ways, guys, we actually have it. We have national evidence-based guidelines. We have hospital protocols. In theory, we could go to any hospital and clinic. And to some extent, kind of what we heard from this morning is stuff is out there, try to figure it out. That's equality. In equality, this person who's there, big blue guy, is in an urban setting, has access to care, has adequate insurance coverage, and has support systems. This person over here is in an underserved setting, doesn't have obstetric services, might not have insurance coverage, and is affected by social determinants of health. But we could still argue equality exists because maybe they could go get it if they want it. But what would equity look like in that situation? What equity would look like in that situation is you have improved coverage, but help to get that coverage, right? Because we know how hard that can be. Making sure that we are taking advantage of things like Medicaid extension, telehealth and virtual health options, support systems in place, granular support systems in place that can actually be utilized and helped, and then actually being able to transport to higher levels of care in a seamless fashion when needed. That's equity. That's not equality, and really that's what we should be aiming for, is equity, not equality. And so when we came to determinants of health, the MMRC actually said that 70% of Georgia's deaths were preventable, and unfortunately the key contributors are all those things we talked about that define equality versus equity, which is affecting our state. So it's poorly controlled chronic health conditions, mental health conditions, health systems with poorly coordinated care. This is the key. And among the solutions, a key component of what the MMRC has said is really following up in that postpartum period with case management, other supports, and other multi-collaborative disciplinary processes. And so when it comes to quality right now and equality, or equity, I can say that probably from a quality perspective, we're struggling when it comes to the postpartum period. And equity is not very high right now because we don't have access and we're having setup issues. So now we're going to go and start talking about a small solution that we've been doing and implementing, and it's not an end-all be-all. I want to be absolutely clear about that here. I don't think this is the end-all be-all. This is just, I want us to open up the room for discussion, thought. This is the next 5 years, 10 years for us to think about this process. Just one way we've started, but this is what we're going to share.
Hello, everyone. Thank you for having me here. I am Natalie, like Dr. Suchi said, and I'm going to talk to you about the Postpartum Cardio-Metabolic Clinic that was opened in September of 2022. So the Postpartum Cardio-Metabolic Clinic at Emory offers all telehealth, virtual, and in-person options, and it's for any patient who had any cardiometabolic complication of pregnancy, and it involves a multidisciplinary care team. So we discuss mental health, we discuss postpartum nutrition, we place referrals to primary care, cardiology, and endocrinology services as needed, and really this is so that we can address this paradigm shift in postpartum care. So the eligible patients include anybody who had any type of hypertensive disorder of pregnancy, any type of pre-gestational or gestational diabetes of pregnancy, or any other chronic cardiometabolic issue that does not include adult congenital heart disease. And so patients are referred either during pregnancy or within 12 weeks postpartum. And again, it's for any diagnosis of hypertension or diabetes. And then we schedule this visit 12 weeks postpartum, and importantly, it does not replace the standard 6-week postpartum visit. And again, in-person, virtual, and telehealth visits are all options for patients to choose. And this patient started in September of 2022, and it is still running strong now. It includes 1 half session per week, so right now, Dr. Suchi is currently doing a Friday morning, seeing 6 patients with 30-minute time slots. And then any patient can be referred within, right now it's within the Emory system or within the Grady healthcare system, or it's patients who are delivering at these hospitals and are getting care by a private physician as well. During our session, we place referrals to cardiology, to endocrinology, to primary care. We also have mental health resources that we've created and can refer patients to psychiatry as needed. And then we also have collaboration with the Non-Surgical Weight Loss Center, the Emory Bariatric Center. This is just to highlight that this is a multidisciplinary collaborative team with cardiology, with endocrinology, with primary care, and with our mental health alliances. And so now for the exciting part where we'll talk about the data that we've collected so far. So I think the first thing that we like to highlight is just what do patients say when they see us for this visit. And really they have no idea why, what happened during their delivery admission. A lot of times they don't know why they were delivered early. They just say, my blood pressure got high and they told me I needed to have my baby. But they don't really truly understand what that diagnosis means. And then explaining the health risks at the time of delivery is really overwhelming. When they've just had a preterm delivery, their baby might be in the NICU, and having that discussion about their long-term chronic health risks can be really overwhelming. And they really appreciate this opportunity to debrief, 3 months after this has occurred, after they've had time to process the experience that they've had for their delivery, and then have time to really have an in-depth conversation. And often they're not aware of these long-term maternal metabolic health risks that we talk about. Also importantly, 50% of patients that we see don't actually have a primary care physician. And these are some of the quotes that we've seen. So I want to do something to get better, but I really don't know what to do. I didn't feel heard. I told them my blood pressure was elevated at home, but the emergency room said that I was fine. Or my child's pediatrician actually is the one who told me that my blood pressure was high. So here are the data that we'd like to present. You'll see in the second column here, there were 93 patients. These data were collected between the September of 2022 to July of 2023. And so of the patients that were referred to the Postpartum Cardio-Metabolic Clinic, 93% of patients attended, 93 patients attended, 57 patients did not attend. And you can see here there's no difference in the demographic characteristics between the patients who attended versus those who did not attend the Postpartum Cardio-Metabolic Clinic. This is again comparing those who attended the PPMC visit versus those who did not attend the PPMC visit. there was a significant difference in the referrals placed to cardiology into primary care, as well as any provider within 6 months postpartum. And there was no difference in patients who had a scheduled visit with endocrinology. There were differences that we saw in patients who had lipids, triglycerides, and a hemoglobin A1C collected within 6 months postpartum, but no difference among patients who received a 2-hour glucose tolerance test. Ultimately, patients who attended the PPMC visit were twice as likely to have follow-up with primary care, with cardiology, with endocrinology, or have these important cardiometabolic labs drawn. We were able to present our findings at the National Society for Maternal Fetal Medicine conference last year, and we're hoping to write these findings up and publish them as well. And so now I'll turn it back over to Dr. Suchi to see if it's worked.
So again, I think the key take-home point is this is not an end-all be-all, guys. Right now, this just started. The goal is to grow it, make it larger. 6 people a week isn't nearly enough. The clinic is completely full every week. We take referrals from anywhere, and it's been an extremely challenging process. So I do want to make that very clear, but we needed that preliminary data to now push for grant funding and to show that we have a foundation for this to work. And I think we've now established that very well from many perspectives, whether we want to move this for legislative purposes or for kind of within our clinical community. So I think we can argue that the quality has gone up, right? Like the numbers aren't great. I mean, it was still like 30% attended versus, 7% who attended any follow-up visits. So 30% still isn't great for attending follow-up visits. We want 90%. But is 30% better than 7%? Yeah, so 30% of people who attended the clinic actually had a follow-up visit with cardiology, endocrinology, or got some labs versus 7% if they didn't have a visit. And there's a lot to be said then about that kind of time point where they've had a minute to process those things. So from that perspective, I think we can say quality went up. And then I think we were actually able to put some equity into this clinic. I've had patients at Grady who they have to take a bus and be able to get to Decatur because that's where the clinic is physically located right now, and that's really hard for them. So I can do a telehealth visit. I do virtual visits all the time. I can tell you they're some of my favorite visits. I have moms breastfeeding. I can see the room behind them. I can see the housing behind them. There is so much you can glean out of a virtual visit postpartum, actually, which you don't glean when they bring in their babies. I mean, I love it too. They're allowed to bring their babies to the visits. They can breastfeed during the visits. They can do anything. So we've tried to keep this as very open as possible to make it available for them. A lot of times they're like, this is the first time someone's really gotten into my mental health. Like, are things okay? Are you okay? So it's been actually a really humbling process for us as providers as well. It's a very emotionally charged morning, to be honest. And as an MFM, I have a lot of emotionally charged situations, but those Friday mornings are heavy when you hear a lot of the stories and what people are going through. And so again, I think we were able to improve quality and we were able to improve equity. Not an end-all be-all, it's a start. So now I want to talk about the future. Where are we going? Because that's the key here. My goal in saying this to all of us is not to be like, great, we have a solution, let's roll. My goal is to say, look, I think we might have something to think about, and can maybe Georgia be one of the lead states on figuring something like this out as the nation, as the Society of Maternal Fetal Medicine, as ACOG, and actually as NICHD in its new guidelines that are coming out for research it wants to support is pushing postpartum health. So I think, where can we go? I think this concept of multidisciplinary postpartum transitions of care is important to think about. It's not easy. I'm not saying it's easy. It's not easy, especially when we're dealing with OB deserts and all the other pieces of life we're dealing with. It's not easy, but I don't think we can ignore it. And when I say I don't think we can ignore it, I mean I don't think we can ignore it just as OBs, but also bringing in our other people. We need primary care. We need family medicine, internal medicine, cards, endo, the entire team. We need to think about that at a larger level. And then mental health resources, can't underscore that enough, right? We all struggle for that. I mean, it's taken me a long time to build relationships with Peace for Moms, the other teams, but how do we grow this? How do we build it? How do we make it more systematic? That is key. And actually, how do we fund this? This is granular, fundable, action-packed items that we can do. This is easy to say, here is a plan, let's try to fund it. Personally, for us at Emory, I want to run this clinic multiple days per week. Hopefully we get it there. I've actually wanted to get our generalists involved in this. Dr. Davenport sitting right here in the audience, and actually she's someone I've already recruited to join if we can get this to that. I don't think this needs to be run from an MFM side. I'm an MFM, I'm doing this. I started it as a process, a pilot from a very kind of, strategic research-based approach, but this doesn't need to be MFM. This can be anybody. This is applicable to all of us. We could use nurse practitioners, advanced care practitioners. It's the concept of how do you bring this data out? How do you use it? There's many ways to do this. So my goal is to get us at least Emory to go multiple days per week, but think about this more kind of as postpartum wellness at a greater level. I've had a lot of people say, oh, I just refer them to cardiology. I just refer them to endocrinology when they come to their postpartum visit. Doesn't help if A, maybe that's not what they need right away, B, most of them need longer term care, and C, most of them don't have primary care, which is really the key concept. So that actual discussion is very important. One thing I want to point out in our results is of the people who came, 50% wanted mental health referral and 40% wanted nutrition referral. We of course can't know the group that didn't come what they would have asked for, but the fact that 50% wanted mental health referral when we really broke down into it and didn't start that way often. The conversation doesn't go that way. It's when you dig deep into them, that's where it comes. And 40% were like, yeah, I want my nutrition referral. That's the purpose of a clinic like this. It's not just, okay, go to cardiology, go to endocrinology. It's actually understanding and meeting the patient where are they at postpartum. Is weight important to them? It might not be, okay? I've had the WOM who is 21 years old with 4 kids, and yes, 4 kids, and to her, weight was not an issue at that time. But guess what? Her heart was an issue. Her blood pressure was 140/90, maybe not crazy elevated, but at 21 with 4 kids and preeclampsia with severe features, that's an issue. And she got cardiology and primary care. And that took efforts to build that process. So again, it's networking for us. We've had to build that network within our system, but how do you do this at a state level? How do you build our networks to have support systems? And again, it doesn't have to be MDs, right? We have OB deserts. We have to be practical about this. We're not maybe gonna get an MD in every corner of the state, but how do you maybe utilize mid-level providers and the telehealth and virtual health models, which yesterday we got such a great lecture on coding and how now actually we can bill for some of these visits. How do we strategically utilize these processes to grow something like this? So that's the key here. And then really the idea is dedicated OB providers to the cause and really pushing all kinds of options. This is my dream in 5 to 10 years, is really to have postpartum health and wellness centers where you actually can deliver at any local regional hospital. You can kind of get funneled in. If you have any of these issues, get placed referral into a process. Again, these wellness centers, they don't have to necessarily just be geographically located. I think that's the key, is for us to break that paradigm, is geographical location is a limitation for this, and to actually be able to think outside and say, how can I reach to people who may not be in my geographical region with the data and with the knowledge? Because half of the battle is the counseling. Then a lot of it goes on the person to be like, oh, I want to do this. I'm gonna try to do this. I think that's a key component of it. And so I think this is the key, is this multidisciplinary connection. You need to have like this association between community, right? Because the first thing is trust. If our patients don't trust us, they're not gonna come to us. So we need to enter the community to tell them, like, this is really important. They need to know you care. Half the time when I start my visit, you can see like they're just gonna be up and they're like, yeah, I'm fine. And then the more you break into them, these visits, they're scheduled at 30 minutes apiece. I'm gonna tell you they take about an hour for me. And I've had to schedule it that way so I can schedule 6 people and everybody knows they wait a little bit. But let me tell you, when I start, it's like, I don't want to say anything. And then slowly it goes, and you build that trust. So how do we get into the communities? How do we improve that care access? And last but not least, how do we leverage technology? Because it's out there, whether it's CGM, whether it's remote blood pressure monitoring, whether it's, virtual visits, other processes. How do we leverage that technology? There's a lot of stuff going on. We have ARPA-H, NSF grants, different things we're trying to put in, but how do you actually leverage this piece and tie it together? That's really important at a statewide level for us to think about. And then we have to speak up. So I am actually a member of the Society of Maternal Fetal Medicine. I am the member of the Health Policy and Advocacy Committee, and I am the chair for postpartum health and that. We actually published this just talking about extending Medicaid coverage, and I give this group a lot of props. I know there was a lot of work done here to make that happen, so congratulations, excellent. But here's the problem: women don't know it exists, and so how do you help them? and how do we make sure it's easy for them to get it? So this article is talking about the extending Medicaid coverage and what it's done and for states not to. We actually have a part 2 coming out that we're writing that's looking at utility of the extended Medicaid coverage. Because again, if states have extended, it's one thing. If it's not being utilized, it's another thing. And so how do we improve that utilization? How do we encourage that utilization? But more importantly, how do we make that utilization accessible so that when they're sitting on their phone at Grady and we're trying to get them on to getting postpartum Medicaid, how do we help them with that? And what resources do we need for that? And then we did do the, for Atlanta Medicine, we did do the edition with the maternal mortality articles, and I think I heard that these were actually passed out here earlier. So again, I think really speaking up is uber important, and we have such amazing people in the state, such amazing efforts already going on. So I don't think it's really hard for us to do the speaking up part at all. I think we have the things to speak up for, and we just need to keep doing it. And of course, I love this quote: do the best you can until you know better. Then when you know better, do better. And I think we know better. Postpartum isn't the same. It's not a 6-week visit. It's not a, are you feeling okay, move on. It's a complicated, crazy process. And I don't know if I'm still allowed to call myself postpartum 11 years out, but sometimes it feels that way. Or sorry, fine. But I'm just saying, like, it's hard. It's a balance. It's a process. And if we don't kind of set that up early at the get-go, I think it's only going to affect the future. So that's that.
I have a very basic question. Thank you for your work on this. It's great. When you are seeing these patients at this visit, do you draw labs then and then follow them up and call them on the phone?
So we can do a couple of things. It really depends. And again, it's kind of meeting them where they're at, right? So if they are open to going to the lab and they can get them done, I'm going to put them in and I can follow them up. A lot of times they end up getting referred to cardiology or endocrinology or primary care. So they're people I know, and I know I can see those labs and follow them up, so I can tell them they can go there and get it done. The lab isn't in the, right now, so the logistics is right now this clinic runs physically at the perinatal center at Decatur, but again, I do the telehealth visits, so if they're on telehealth or Zoom, I can tell them they need to get it done. The funny thing is, you'd think people don't go get their labs done, but they actually do. After you've talked to them about all this stuff, they're like, oh, I need to go get an A1C. Oh, I need to get lipids drawn. I need to get this drawn. So it really varies and depends. Again, we would like to build this to more like a multi-center process, running 2 to 3 days a week, including our generalists in the process, because again, we don't need this to be an MFM process. It just started here, but this is beyond us. This is beyond everyone. And so I think, my dream is the labs get drawn there and we can do everything. Great question.
Thank you. This is something that I'm very interested in. And one of the things I was thinking about and just wanted your ideas, along with the telehealth visits, because I think that's going to be paramount, especially with the fingerprint of Georgia and not having providers. Any thoughts about getting blood pressure cuffs in the hands of all these patients so that you have that additional piece of information with vital signs for telehealth visits, and thoughts about remote centers, like having a monitor with Wi-Fi connectivity that people can do telehealth visits like in the grocery store? So there could be a blood pressure monitor. They go in the room, the screen pops up. Hi, how you doing? If they don't, because we have patients who don't have Wi-Fi, who don't have phones, those are going to people put them in the grocery stores in the really impoverished areas and let them come do their postpartum visits there. So any thoughts about anything like that?
All thoughts, all agreed. Yes, all the things, right? Like, I've put in a grant where I think we should use our brick and mortar DPHs in some of the rural sites and put an APP there and then have people go there and get a blood pressure. Because one thing, so I will tell you, this is a very personal pet peeve with blood pressure cuffs, is because it can vary so much, it is a challenge. That being said, if you have a blood pressure that's showing 200 over 100 versus a 140 over 90, I know there's a problem, right? So to me, the home blood pressure cuff is not now about ACOG guidelines of, am I starting medication or not? It's more about, are you sick or are you not? It reminds me of like a PFT that I use during asthma. Like, are you red, green, or yellow? That's kind of how I'm looking at that home cuff. That being said, we actually have a study right now through NIH we're running with 10 different devices, looking at different methods to validate blood pressure monitoring with like wristwatches, stickers, the other things. And so I think the future will take us there. I mean, the technology is going there, so I don't think we'll be stuck to the cuff forever. But no, you're absolutely correct. Like, that's why I'm bringing this up here is, this is not an individual problem. It's a statewide issue. And I think, yes, why not? We have DPH brick and mortar buildings and locations. We actually have another abstract that went in. I can't give the data for SMFM, but ultimately, let me put it this way. There's a lot of providers out there in secondary level, not MD, but APP, NP, and all that. But if we don't train specifically for pregnancy, that's the issue, right? Because for most people, if you see a 140/90 blood pressure, that's not scary to them. So I think very direct, and I've had patients say that. I went to the ED, I had a 140/90, they sent me home. Of course they did. That wasn't scary to them. According to the AHA, that's barely level 2. Who cares? For us, we know better. How do we teach that? How do we get that out there? And I know there's so many efforts here. I mean, Teresa Bird is, you've done this. You're doing it. We're all in it. But yes, I agree. That's what we need to do, and think outside the box for all these ideas, and then actually ask for funding for these granular methods to be able to push them forward.
Thank you. Strong work and advocacy. So, a great victory, 12 months postpartum, Georgia Medicaid, granted. I saw 3 patients in the high-risk OB clinic last week that had a BMI over 70. And before this extension to 12 months, I had a conference call with one of the state representatives, and I said, bariatric surgery, in my mind, is something that we need to push forward. When you have a 23-year-old that's 450 pounds, Bob Barbieri said this many years ago in an editorial. He stopped advocating for weight loss in patients with infertility. He went straight to bariatric surgery after many years of frustration. And so basically, I've contacted the private docs that do bariatric surgery. I've contacted the university docs. No one will do bariatric surgery for Medicaid patients. And so is there anyone in this room that has witnessed a single patient have bariatric surgery within 1 year? I bet you it's 0, okay? So I think it's fine to tune these patients up, but you need to get them optimized medically. I've seen family members need multiple knee replacements and hip replacements because they're 300 pounds. When you're 500 pounds, you're going to have a sudden death. It may not be in that 12 months, but it's going to be within 5 years.
Yeah, I actually have another whole talk because my entire research is on obesity, brain, and metabolic health. You guys don't want to hear about it. It's a bit late right now. I get it. But I actually have a slide on there specifically that looks at outcomes post-bariatric surgery and pregnancy for future pregnancies. Again, the data is out there, guys, especially if your BMI is above 60. It's significantly helpful, but we have to keep talking about it, putting the data out there so that we can actually get funding for it.
The other thing is that when you knock on a bariatric surgeon's door, you do not have surgery the next week. It is often 3 to 6 months of psychological counseling, dietary modification, proving that you are capable of post-surgery maintenance. And so my thought is these patients should be seeing the bariatric surgery at 6 months of pregnancy, so that once they are 3 months postpartum, they're ready for the surgery.
Lots of things to do.